Hello everyone. We have a 34-year-old man who come to you due to foul-smelling anal discharge and perianal discomfort for the last several weeks. Patient has a history of recurrent anal fissure and take a fiber supplement, stool softener and topical analgesic. He also has occasional canker sores, so-called Aphthous ulcer, and recurrent abdominal pain and diarrhea. Well, the patient smokes a pack of cigarettes daily. He has fever at the moment. Tenderness is present in the right lower quadrant on deep palpation. Perianal examination shows a large posterior skin tag. A fistula anterolateral to the anus is draining whitish material. Well, on further evaluation, the patient most likely to reveal which of the following. Answer is transmural bowel inflammation. This patient has most likely Crohn disease. This can involve any component of GIT right from mouth to anus. Classically, skip lesion are seen. This, if you are getting the word skip lesion, this is a golden line to remember. Okay, skip lesion are seen this in Crohn disease. Anal fissure is seen in 20% cases. In this case also recurrent fissure are there. After ulcer, so-called canker sore, occasional component, but they are fairly non-specific by themselves, but they are one of the earliest feature of Crohn disease, although non-specific. This is a skip area that we see. You can see skip areas in between. In Crohn disease, skip areas are seen. This is involved, this is involved, this involved, this involved, this involved. Patches are involved. In between, the intestine is normal. And one more thing you note, it is involvement of large intestine as well as small intestine. This in contrast to ulcerative colitis, it is involved, a continuous is there and small intestine is not involved. Very rarely, terminal 2 to 3 centimeter of small intestine may be involved, but uncommonly. And if this happens, we call as backwash ileitis. Okay. Now, this Aphthous ulcer is one of the earliest feature of Crohn disease in the mouth. Skin tag and fistula are common perianal manifestation. Other GIT symptoms include chronic diarrhea or abdominal pain, like this patient also. Extraintestinal feature can be arthritis, skin lesion, and lung disease. In arthritis, it can be sacroiliac joint involvement, which can lead to back pain. Although this is more common in ulcerative colitis as compared to Crohn disease. Crohn disease commonly in the patient in the age of 15 to 40 years. Our patient is 34 years. A slightly female predominance, but not much difference. Smoking is the risk factor. Patient smokes a pack of cigarettes daily. That's one condition that is risk factor for Crohn disease. Diagnosis can be confirmed by endoscopy or other imaging studies demonstrating consistent finding strictures. Okay. Typically, biopsy reveal a focal ulceration with transmural inflammation. Granulomas are common. They are non-caseating. Non-caseating. Treatment include 5-aminosalicylic acid for patient without systemic symptom and steroid or biological like infliximab for patient with more severe diseases. Now let's look into other option. A. Colonic ulcer containing protozoal cyst, Entamoeba histolytica, which can lead to amoebiasis, can also cause abdominal pain, chronic diarrhea, but they rarely cause perianal disease, not a feature. stool are more commonly bloody and enema histolytica would not explain this patient oral ulcer. This is not there. Of course, they can lead to liver abscess. Diffuse colitis with no skip lesion. This is ulcerative colitis. Diffuse colitis with no skip lesion, I mentioned to you, and this involves only large intestine, and colic abdominal pain and inflammatory diarrhea can occur in this patient. However, GIT involvement is limited to colon, and both oral and peripheral disease like anal disease, perianal disease is usually uncommon. Tag fistulas are not seen, although rectum is the most common site to be involved, but fistula formation is not a feature. Lymph node with caseating granuloma, this occurs in tuberculosis. No doubt TB enteritis would be included in DD of CD. In fact, Crohn disease and TB are close, almost close, very, very close. They have a similar type of presentation. However, in TB, fever, weight loss, etc., are there, and these are a feature of TB. But oral ulcer is not a feature of tuberculosis. Segmental inflammation of mesenteric artery, vasculitis like polyarteritis nodosa can present with recurrent abdominal pain and diarrhea. But abdominal pain is frequently postprandial as a result of chronic mesenteric ischemia. And this pain is mainly usually in the periumbilical area. And classically, the pain is out of proportion to physical signs. Now they have other features like asthma nodosum, renal and neurological feature. Fistulas are not a common complication of polyarteritis nodosa. But I have a question for you. Stop the video, write down the answer. Which neurological features can be seen in a case of polyarteritis nodosa? Write down the answer. Mononeuritis multiplex is in fact, the PAN is the second most common cause or among the common causes of mononeuritis multiplex. A quick recap about last minute point about Crohn disease. Involvement extending from mouth to anus, mostly ileum and colon. Rectum is spared. This is involved in ulcerative colitis. Perianal disease is positive. Skip lesion are the classical. This is the golden line to remember. Non-caseating granuloma is biopsy. Gross transmural inflammation, linear mucosal ulceration, cobalt stoning, creeping fats are seen. Diarrhea, bloody if colitis is there, intestinal complication, fistula, stricture, abscess. Golden line to remember, Crohn disease can involve any component of GIT, mouth to anus, Aphthous ulcer, perianal skin tag and fistulas. Biopsy include focal ulceration and transmural inflammation, and you get non-caseating granulomas. Well, I hope you liked the session. Just to inform you, we have following courses for you. Smart Medicine. There are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading one page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these 3 things are more than enough for your MD, DNB Medicine and Family Medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These three are complete in all the aspects. For more detail, you can contact at this number. It's a for mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.